Good afternoon, and thank you for joining us today for our 5th Community of Practice Lunch and Learn webinar. My name is Becca Newman, and I'm a project coordinator at the Center for Behavioral Health and Justice, a community-based research center that provides local communities, organizations, and behavioral health and law enforcement agencies across Michigan with technical assistance, evaluation, and support to optimize diversion of individuals from jail and prison through the implementation of best and innovative practices at every intercept of the criminal justice continuum. This webinar is part of our Opioid Treatment Ecosystem Initiative, OTE, which is a technical assistance framework aimed at strengthening community-based substance use disorder treatment at the intersection of criminal legal systems. Through this framework, the CBHJ has convened county-level change teams that feed into the larger community of practice, including all of you who have joined us here today. Collectively, this community of practice is working to provide life-saving medications for opioid use disorder in jails, ensure continuity of care to prevent overdose upon release from jail, and connect first responder and behavioral health systems to increase community-based treatment access. Today's event, and those we will hold in the future, will be focused on sharing new ideas, addressing common barriers, and allowing for discussion to encourage expansion, enhancement, and sustainability of county-level treatment ecosystems. Generous support from the Michigan Health Endowment Fund has made it possible for us to offer this event as part of the OTE community of practice. Before we get started, we have a few housekeeping items. First, audio-visual capabilities have been turned off for attendees to limit distractions throughout the presentation, but we do encourage you to ask questions of the presenter. You may enter your question in the Q&A box on your screen at any time. We will address questions as time permits during the roundtable discussion portion of the event. If you are calling from a phone, please press *9 to raise your hand and ask your question. Today's OTE Lunch and Learn is enhanced drug checking, spectrometers implementation, and policy considerations. To kick off the event today, I'd like to introduce Maya Doe-Simkins. Maya has been in the public health field for 20 years, training on and researching such varied topics as HIV prevention, harm reduction, and safer drug use, and overdose prevention. Maya is particularly interested in the integration of public health, substance use disorder, and mental health treatment with a focus on evidence-based practices like opioid agonist treatment, syringe access initiatives, and overdose prevention practices. She has worked with the largest overdose prevention program in the United States, helped launch the first overdose education and naloxone distribution program using nasal naloxone, and was part of the team that published the first effectiveness studies on community naloxone distribution. She has worked with both grassroots and local and state governmental organizations to establish prevention programs, authored manuals and curricula, and has published scientific research. Thank you so much for being with us again today, Maya.
Hey, Becca, thank you so much for inviting me. And thanks, Matt and Aaliyah, for all your help in putting this together. It's really exciting to be back chatting with you all about drug checking. So this is something that is, oh geez, my phone's making noise already. I'm gonna shut it up just so it doesn't distract us. This is something that is, depending on the type of technology being used, is relatively new, and there's a steep learning curve, and it's still relatively uncommon. However, using technologies like fentanyl test strips, community-based drug checking is becoming more and more and more common. So let's just jump in, and I'll look forward to having a Q&A and further conversation as we move along. So I just want to appreciate these 4 folks in particular. Some of the slides and content we have either collaboratively developed or I just straight up snatched from some of them. So these are some of my colleagues and friends that are part of the Alliance for Collaborative Drug Checking as well, and really drug checking pioneers in the US. Let's go on to the next one. Before we get too much into advanced technology drug checking, I think it's really important that we contextualize the idea of drug checking. And given that the substances that most of the substances that people are consuming may be part of a illicit drug market, there's been a long-standing practice of people who use drugs using their senses for drug checking. So, what does a sample look like? Does it look different than it has previously? Does this sample of cocaine have little iridescent flakes in it? And what does that mean? What does it sound like when, when we're smoking rock cocaine? Does it sound similar that it has in the past, or does it pop differently? Do we get an audio rush from a certain substance that either is common or not common with using that particular substance? And what does that mean for the quality and the content of that substance? How does something smell or taste? This is also like very, very common that people do in advance of using the substances. One of the earliest pieces of information that we had as fentanyl started to become more and more common in our heroin supply is that it had a very sweet taste to folks who would use it, including by injection. So there'd be a sweetness in the back of their mouth on folks' tongue that wasn't necessarily there with heroin. And similarly, that it felt a little different, that there was a rush at the top of the head that some folks reported that just wasn't super common with heroin. So we have long used our bodies to check the quality and regularity of the drugs that we consume. And so I think it's this underlying long-standing history is important for a couple of reasons. One, it lays out the fundamental importance of the active involvement of people who use drugs in any drug checking initiative. People who use drugs have, regardless of how super duper schmancy and fancy the technology is, how well funded a drug checking project is, nearly every single time there was a eureka moment using drug checking technologies, it was foretold by people who use drugs because something was different in the regular drug supply. So doing drug checking without the active involvement of people who use drugs, and I mean that not necessarily as people bringing in, the active involvement of them checking their own drugs, but involved in the process of designing and implementing and interpreting drug checking results is foundational. And the other thing the other reason that this point is important is that it pushes back against the notion that people who have substance use disorders don't care or are will consume anything that they can get their hands on. People actually are very invested in being informed consumers and making as much of a informed and intentional choice about the substances they consume as possible. And it is the fact that that so many substances are acquired on an illicit market, that an unregulated market, that makes it so challenging and also so important. Next slide, please. I'm going to just talk a little bit about the preferred components of drug checking. This is from a harm reduction perspective. So just a few bullet points. One that's really helpful and important is if it's real time. So meaning right now I can get the results of my drug, of my drug checking activities, and then I can immediately use that information to make decisions about how I may want to be consuming substances and what safety strategies or pleasure maximizing strategies I want to implement. In the absence of real-time drug checking, there's always something useful about knowing in general, but a considerable portion of the actual moment-to-moment utility of drug checking disappears if it's not real-time, like if it's a lag time, if you have to send off the sample, and you can't have that information right off the bat. Almost always we see this happening, that we use non-real-time drug checking after the fact, after somebody has had a really terrible experience, or after an overdose, or after a group of people say something's really not right with this. Then we oftentimes try to track down a sample of that particular substance and send it off. So it's always helpful, and it's nice to sort of be reassured that there was something unusual about this particular sample, but all of the informed bodily autonomy, informed consumer benefits of drug checking are null and void in the absence of real-time drug checking. Another important component is that it's drug user facing. This means that in the conceptualization of and the implementation of and the putting together the policies and practices and the rollout of drug checking projects, the people who use drugs need to be centered. So this is another reason why there should be people who use drugs as part of the implementation and rollout teams. There are ancillary additional benefits like research, like surveillance, like knowing what's, having a sense of what is, what's going on the ground in a more real-time setting. But those are ancillary benefits. So the drug user priorities and that interface needs to be primary. Another important component of drug checking is that it has to be reality informed. And so I mean this both super broadly and very super specifically as well. So super broadly, I mean, the people who are engaged in drug checking have to be aware of the reality of drugs in the US and not wildly vulnerable to amplifications of really, I guess I would say like drug hysteria. People involved need to know that fentanyl in weed is not a thing and know how to be suspicious of hearing some really wacky, intense or unexpected drug combinations. And so knowing what is possible and what isn't possible is important broadly. And then also reality informed very, very locally, needing to know like what is normal for our illicit drug markets. What is what is the usual? And so just, in Michigan, if we were to find an enormous a big supply of tar heroin, for example, that would not be super normal, but it is super normal in the Bay Area, in California. So people need to know what is the reality of the drug scene in a very local sense, because more important than exactly what is in a drug sample or what percentages of what is in a drug sample is it similar to or different than the regular drugs in our drug scene locally. Another component that's very important for drug checking is that it's meaningful and actionable. Oftentimes there is a tendency to be like, holy crap, we just discovered this wildly scary drug sample. So the messaging out is be careful, the drugs are dangerous. This is a perfect example of non-meaningful and non-actionable information that could come out of a drug checking initiative. We need to know very specifics. We need to be able to provide meaning in terms of helping people be able to identify that particular sample in their regular day-to-day and what to do, what actions they could take that would minimize risks and maximize benefits. And another hugely important component of meaningful and actionable drug checking information dissemination is it should be dated. It is unhelpful and unmeaningful for me to get information about a drug that was discovered, a really, really intense drug sample from, 2020. That's not helpful because I need to know now. So all of this information should be dated too. And then another component is that it needs to be harm reduction based. So there's this kind of logical, there's this logic around drug checking that goes something along the lines of this. If we can check somebody's drugs and we can see that there's a scary amount of a particularly strong fentanyl analog, then we will expect a person to not use that particular sample because it's dangerous, because there's a strong fentanyl analog. That's the kind of logic around drug checking. And what we find is that that's often not the case. It's considerably more nuanced and it depends on many, many, many components. And so to be able to maximize the benefits of the information gleaned from drug checking, the services must be based in harm reduction so that we can have a tailored, meaningful, respectful, authentic dialogue with a person or group of people about their particular drug samples. So those are the necessary components for drug checking as we've discovered from people who use drugs. So next slide, please. I do want to say that we're hearing a lot more about drug checking, both fentanyl test strips and spectrometers recently, but I definitely want to give a nod of appreciation for some of the early pioneers in the US of drug checking. I think DanceSafe is one of them. What you see in the upper left is a tent, a DanceSafe tent that is at a festival. DanceSafe has been doing drug checking since the 90s. Very, very, very long history of drug checking there. What you see on the right-hand side is a reagent key that most of the DanceSafe drug checking initiatives involve using reagents to, you add this little drop of a particular chemical and it will react with different drugs in different colors along a spectrum. And so, DanceSafe has been doing this for way more than 20 years. They are absolutely pioneers in drug checking. And so even though we are using drug checking technologies in a sort of opioid and fentanyl facing manner now, we have lots of lessons to learn from our friends and colleagues at DanceSafe. Click ahead again, please. Yes. So I also wanted to mention our friends at Arrowhead and Drugs Data. So what you see on the right-hand side here is an example of what used to be called ecstasy data and now is called drugs data. It's available online at drugsdata.org. And they have also been doing mail-in, so not real-time, but mail-in drug checking for many, many years. And it used to be that they were largely focused on MDMA and Molly, ecstasy, but much more recently, in the past probably 3 or 4 years, they have intentionally recruited and branched out to other types of substances. And so now they do lots and lots of drug checking on opioid samples, stimulant samples, various pill samples, and then they publish those results of their drug checking on the internet. So this is a fantastic resource for folks. So please check it out in your in your spare scrolling time. But just a shout out to the Arrowhead and Drugs Data folks, that they also are US based pioneers in drug checking that long predates any of the fentanyl facing drug checking initiatives that we are seeing more currently. Next slide, please. So drug checking among people who use drugs, just sort of going along a historical timeline. We had the reagents, we had the drugs data folks that use the technology the drugs data use, by the way, I forgot to mention, is a GCMS, a gas chromium mass spectrometer, big fancy stationary lab that they use to, that's a technology that they use to check the substances. In the fentanyl facing era, we have seen fentanyl test strips, and I want to give a shout out to our Canadian harm reduction friends and colleagues whose idea this originally was, to use BTNX, urine dip immunoassay tests or strips for testing for fentanyl. It came to the US through a couple, US based pioneers, probably Jess Tilley, Van Asher, Tino Fuentes are some of the folks that learned about this from our Canadian colleagues and pioneered this among folks in the US. In addition to fentanyl test strips, you can also use benzo test strips. There's a few more limitations with the benzo test strips than the fentanyl test strips, but we are seeing that this is a very scalable, pretty reliable, if we can pay close attention to potential user error, way to check substances for the presence or absence of fentanyl and many different fentanyl analogs. So next slide, please. Now let's talk about field spectrometry. So the initial use of field spectrometry for drug checking was aimed at and designed for police and law enforcement. What you see on the left hand there is a police officer holding a MX908, which is a drug checking device put out by 908 Devices that is designed to identify only a relatively small number of but particularly fentanyl and fentanyl analog facing substances. And they're used in the field, and their intention is to, they're used as tools to detain and arrest people and incarcerate folks. Next slide, please. So I think that it's really interesting, and I should say various field technologies. I think this is a really interesting opportunity to think back on harm reduction's historical liberation of technologies of oppression for to repurpose them for technologies of autonomy, to liberate those technologies for autonomy. And I think that the perfect example, that predates spectrometry is naloxone. Naloxone, for when it was developed, was used exclusively by hospitals and pre-hospital emergency medical services, and it was very tightly controlled. When the naloxone became liberated from the medical system that it was initially involved with and disseminated through drug using communities, it offered up the opportunity for more drug user autonomy and decision making around potentially fatal overdose events, and helped people make decisions about how and if and when they wanted to interface with law enforcement and emergency medical services. So I think that sort of historical liberation of technologies is something that harm reductionists are pretty good at, and we can consider that as a similar situation here of liberating the technologies that were designed for law enforcement to detain and incarcerate folks, to actually improve autonomy and being able to make informed decisions as a person who uses drugs. So these are 4 major technologies right now, and they vary pretty widely. These are field capable technologies. So on the very left-hand side, you see what is branded as a true narc. This is a very handy dandy little baby device that can check substances for a relatively small library. It's this particular device uses what's called Raman spectroscopy, and it has some considerable vulnerabilities as well. Raman spectroscopy is one of the more underdeveloped types of spectroscopy for checking illicit drugs. This particular device is responsible for that initial fentanyl in weed hysteria that came out of New Hampshire that was later absolutely debunked with confirmatory testing, but that didn't quite make the media rounds as much as the initial untrue information was. So on the left-hand side, True Narc, that product runs between $10,000 and $15,000. Second to the left is the MX908. This is a high pressure mass spectrometer. This one, both of the ones on the left are hyper simplified with very limited results that the person using the drug checking device sees. It says, put in a thing, and then there's a message of what is the thing, right? It also neither of these devices tell you anything other than the active drug. So it doesn't talk about any cuts or other adulterants in the substances. The MX908, the second to the left one, runs about $65,000 per device. In field testing these devices in a harm reduction syringe service program setting, both of these left-handed devices have failed pretty considerably, to the point that there is not a harm reduction based drug checking project in the US or maybe even Canada right now that would encourage the use of either of these 2 devices, but they're definitely out there and being marketed relatively heavily to law enforcement members. Over to the second to the right, we see the BTNX fentanyl test strips. Now, a lot of folks are like, well, now that we have these fancy technologies, like, are the test strips even worth it? I mean, doesn't everything have fentanyl in it? The answer to that is yes, the fentanyl test strips are absolutely still necessary. They have the lowest detection threshold that's of any of the field usable technologies, and they remain, even with fancy advanced technology spectrometers, they remain some of the most, they remain a backbone. And so you can't get rid of them, even if you have a spectrometer. They detect at the lowest threshold. So they're still an important part of drug checking. And also, it is indeed a misnomer to say that all the drugs in our illicit market have fentanyl. That is not, that varies regionally, and there's still many regions in the US where there's heroin in the absence of fentanyl, and there's actually very few regions in the US where there is regular and consistent fentanyl in the stimulant supply. That remains actually relatively rare. So over on the far right-hand side, you have the FTIR spectroscopy device. This is a Fourier transform infrared spectrometer, that the FTIR, and so I'll shorten it to FTIR for the rest of this one, or the rest of this presentation. This device is the one that most of the harm reduction based programs are currently using. It runs about $38,000, and this little device that you see right here attaches via cords to a laptop computer, where you see relatively detailed actual spectra of the actual device. So I'm going to go into that one just a little bit more. Next slide, please. So I'm gonna go into the FTIR a little bit more, because this is the current favored device. On the far left, you can, if you want to get real close, because it's real small, but you see the actual results of what you would find from running a test on the FTIR that's the spectra. And the way that it works is it matches what it's reading on the little device with a vast library of known substances. So it says, this looks most like this. So what the FTIR absolutely can tell us is that the major components in the sample, so it can tell us the active drugs, the cocaine, the methamphetamine, heroin, fentanyls. It can also tell us cuts, buffs, adulterants. So it can tell us if there's quinine, it can detect diphenhydramine, it can detect lactose, mannitol. So this gives us a much more sophisticated and detailed snapshot of what is normal for our local drug supply. And this is just like one interesting anecdote, is when we were rolling out a drug checking initiative in Chicago, we found that we were checking a lot of drugs that were sold as heroin, and that the ones that had quinine in them were more likely to have fentanyl than the ones that had a different cut that wasn't quinine. So, acetaminophen or what have you. So it was just really interesting to say that, okay, there's like clearly a cut, adulterant, buff recipe that varies, that can influence which of the other substances might be in it. And this is meaningful and important because if the FTIR misses a fentanyl, but we see the quinine, then we think, well, there might be a fentanyl in there that we missed. So that's an example of why it's meaningful to also know the mix of what's out there. So the FTIR uses massive libraries to identify bajillions of substances. I mean, we're not just talking about drug substances. It would, you can test many, many, many things on it. And we use a variety of different libraries. So there's a library called the Tic-Tac library. There's a Georgia Crime Lab. There's a library that was created by the British Columbia Center on Substance Use. And so we use these to layer on the different samples, the known samples against which the software runs and compares the spectra that we see, that is brought into us. The other thing that the FTI tells us that is very, very appealing is a rough idea of quantification. And what I mean by that more specifically is it gives us a general sense of how much of what. So it can tell us in one sample I saw it was 27% cocaine and a whole 6% of one thing, and then a bunch of lactose, and then maybe a little bit of levamisole, and it can give us an approximate percentage of quantification. This is meaningful to help us understand what's strong, what's less strong, and also what's normal. What's normal for strength in Philadelphia is different than what's normal for strength in Boston. And this matters because we need to think of this concept of like community tolerance. And if our drug using community is used to a higher proportion of opioids or strong opioids in the regular and common illicit drug supply, that would mean that somebody who came in from out of town, who is from an area with the average strength of the illicit opioid supply was a little lower, might be at risk. So it gives us the idea of quantification is really helpful to say, expected versus unexpected. Now, what the FTIR does not tell us. It doesn't tell us about teensy tiny small amounts of substances. And I mean, not just, I mean, you can test a teensy tiny little bit. I mean, the amount of drug or drug debris that we would check is, half the size of a grain of rice. It's very small. But what I mean more specifically about small amounts is small percentages. So out of the box, the FTIR is set, the manufacturers will say that it doesn't easily and consistently detect anything lower than a 5% threshold. So this is important because we know that in some opioid samples, certain fentanyl analogs may be present in percentages lower than 5%. And those percentages, even though they're low, may be very clinically meaningful in terms of people's response and potential for overdose. So this is one of the main reasons why fentanyl test strips remain a backbone. We need to be very careful with the quantification that the FTIR tells us. So it doesn't provide like for sure validated consistent quantification. The quantification that it does provide is it uses an algorithm. And so we see that there's some variance between what we see with quantification when we do a confirmatory test versus the field-based FTIR sometimes can vary. So we need to be very careful about making statements like this cocaine sample has 27%, which is weaker than this cocaine sample that has 32 or 35% cocaine. That level of variance is not quite big enough for us to be able to confidently make a statement like that. So we need to be pretty careful with the way we interpret the quantification capacity of the FTIR. The FTIR also does not identify all of the specific fentanyl analogs. Many times there's a fentanyl analog that it identifies just as a fentanyl. So it can do some analogs, but we find the detailed analog analysis when we do a confirmatory test using either GCMS or LCMS stationary labs. And then another thing that is particularly important in the context of fentanyl is that the tiny little half grain of rice sample that we put on, what you see with that image there is that there's a little teensy tiny circle in which is a teensy tiny square, and you place the sample on it, and then you pull that lever down so it smushes it, and then it runs all this light through it, and that's how we get the result. Because fentanyl has this capacity to do what they call like a chocolate chip effect, meaning there's a little chunk of fentanyl here, a little chunk of fentanyl here. If you take a bite of the chocolate chip cookie, it's possible that you might not get a chocolate chip. I mean, not if you're buying Toll House, but any other type of chocolate chip cookie, you might miss a bite that has a chocolate chip in it. And it's the same kind of, we use that analogy for that effect of fentanyl too. So if we just choose a sample out of a bag that doesn't have the fentanyl in it, we absolutely could miss it. So that's a risk as well. Next slide, please. So both the previous slide and this slide specifically, I snatched from Sarah Mackin and Claire Schmidt. I snatched from Schmidt. So I want to give them a shout out there at AHOPE in Boston. And so this is just how somebody who comes into the needle exchange there would the life cycle of their sample. First, the person would give the drug or the residue. So you can test baggies, you can test cookers that have been used only once. And they would run it on the FTIR, and then after running it on the FTIR, swipe the spot where the sample was and put it with water and run the fentanyl test strip or benzo test strip second. And then after that, using the results of both of those technologies and triangulating what the FTIR finds with what the fentanyl test strip finds, the trained technician would then communicate the results and the implication of the results to the person who uses drug. Here we see the people in these slides are just to shout out some awesome folks. Sam Tobias is the lead technician for the British Columbia Center on Substance Use Drug Checking Initiative. He's in the blue shirt. Greg Scott is in black there next to Sam. And then Tino Fuentes, who I mentioned previously is one of the people who brought fentanyl test strips to the United States, is there with the Kangal on. So After providing the results to the participant and with the participant's permission, the sample can be sent off in the mail for confirmatory testing. So either LCMS or GCMS confirmatory testing. And the usefulness of that is to recompare for the purposes of quality assurances that what we thought we saw in the FTIR and the fentanyl test strip is indeed what they find on the LCMS or GCMS spectrometers. So next slide, please. This is a little bit of an old slide, but I wanted to also, and I don't have an updated slide. It's a couple years old, but I just wanted to mention that there's many drug checking services, that meaning formal, legal, acknowledged, supported, paid for by the government drug checking services in the world. There's some that's been going on in Europe for as many as 30 years. Energy Control has been around for forever, for example, as well as in Australia and New Zealand. They've had drug checking initiatives using spectrometers for many, many years. In the US, it says 2, and so this predates some of the more frequent or more recent ones. At this moment, using advanced technology spectrometers, so not exclusively reagents or fentanyl test strips, there are 4 initiatives that are not research projects, but are harm reduction projects operating at harm reduction programs that are operating in the US currently. But in the next 3 months, I know of at least a dozen that are in the process of launching. So next slide, please. There is a pretty steep curve here with learning how to use the spectrometers. And so what we've done is we've created a learning community. That's what the Alliance for Collaborative Drug Checking, is ACDC, is what we call the learning community. And here we have some folks this was the very first FTIRs that were purchased for needle exchange based drug checking. And here we are, there's folks from San Francisco and Portland, Chicago, and Boston here, all trying to figure out what to do. We're at the headquarters of Bruker, is the company that makes the FTIR that many of us use. And so we're there with their team, trying to figure out how to check illicit drugs, using their technology. So we've created this learning community where it's a Google group, it's a monthly phone call, it's an annual summit. And so given that opioid facing and fentanyl facing drug checking is very, very new in the US, there's a steep learning curve, and we need to continually feed off each other as we discover new things. This is important because one of the things that we collectively discovered is that diphenhydramine, which is the active ingredient in Benadryl and Dormans, diphenhydramine, is a very, very common additive to heroin in certain places. It's pretty ubiquitous. In Chicago, for example, is mixing Dormans in with heroin. People are really used to it. But it seems that diphenhydramine can sometimes either trip a false positive for fentanyl and fentanyl test strips, and it can also shield or mask a fentanyl in some of the FTIR spectra. And so, we wouldn't have learned this if we weren't talking to each other in this learning community context. So next slide, please. The broad strokes results is some of which are very surprising and some of which are less surprising. One is that the fentanyl and the opioid supply varies very widely. So if there's one thing I can say from the context of drug checking is, please let us not fall into the trap of saying there's fentanyl in everything. There isn't. There's not fentanyl in everything. We need to know what is normal for our areas, but there's definitely still heroin, and there's no fentanyl in weed, and there's very rarely fentanyl in any stimulant. It's much, much, much more likely that a person makes a mistake, and in an area where, for example, the normal heroin was brown powder, and the white powder is cocaine. If you see a white powder, it's an assumption that it's cocaine, but perhaps it's actually fentanyl is the white powder. And so that is the result of an unregulated, unlabeled, unreliable drug market where a person mistakes white powder fentanyl for cocaine, for example. That can happen, but cocaine that contains clinically meaningful amount of fentanyl, methamphetamine that contains clinically meaningful amounts of fentanyl are still the absolute exception, and certainly not the rule. So that's one thing is that I would encourage us to not feel fatalistic about the ubiquitousness of fentanyl. The other thing that's interesting that we found is that the varieties of fentanyls are not nearly as huge as they could have been, or they could be. There's actually just like a few kind of regular go-to analogs that are consistently being found. And ideally, this is what we want. What we don't know is in the earlier days of fentanyl analogs, if there were way more, and then the drug suppliers and drug manufacturers sort of distilled out the easier ones to manufacture and the preferred ones of people who use drugs, and just stopped with the ones that were harder to manufacture, or were causing overdoses, or were not preferred, and continued on with some of the analogs that are I don't know, a little bit better or more predictable. So that's a possibility. We weren't doing enough drug checking then to know, but there's not quite as many fentanyls as we thought. And many of the things that are framed as fentanyl analogs, like 4-ANPP, for example, are not actually fentanyl analogs. They're byproducts and metabolites. So when we find those in a drug sample or in postmortem toxicology, it's common to see that 4-ANPP, just as an example, split out as if it were something separate, like a separate analog, when indeed it's not. It is, you won't find it in the absence of a illicitly manufactured fentanyl. So another broad strokes lessons learned is that the eureka moments are nearly always foreshadowed by people who use drugs. We are able to confirm them using advanced technologies, but like when Atizalam popped up in Vancouver, it was people who were doing drug checking paid closer attention, because the drug users were like, something's going on. So it's very important to have a two-way conversation and information flow with people who use drugs, and to have people who use drugs on drug checking teams. I already said that one. So definitely Atizalam, xylazine, et cetera, are definitely a thing. There are additional non-fentanyl adulterants that we're seeing in substances. But the problem is that when we use overdose as the sort of main indicator, or the variable of interest, we miss out on other more common and more meaningful experiences for people who use drugs. For example, some of the skin and soft tissue infections that we're seeing with xylazine, which is something that, for example, our friends in Puerto Rico have known for years. Xylazine was identified in Puerto Rico in 2006 or 7. So there's lots of opportunity to rely on existing knowledge as well. And I think this last point I've made before. So next slide, please. And let's go to the next slide. We'll stop with, I have a bunch of frequently asked questions that we can go through if we want to, but I wanted to let folks on the session come up with questions if you want. I did want to just say, hey, save the date. So this is what I was talking about. The ACDC Alliance for Collaborative Drug Checking Annual Summit is, and this is, ACDC is it's a loose group, and this summit is a sort of unfunded volunteer put together initiative of ACDC, but it will be November 3rd through 5th of this year. It will be online, so not in person. And you're welcome to join us. I don't have specific join details yet, but there's a planning meeting tomorrow where we're going to figure out our registration link. So please circle back to the folks who put together this lunch and learn if you're interested, and I can be sure to pass along that information. I think I'm going to pause there for a second. Maybe we can stop screen sharing, and I'll hand it over to Matt, and then we can maybe do some questions or thoughts.
Thank you, Maya. I'm always just blown away by your presentations here. The content expertise you have in here is so easy to see. The flow with which this all comes out and the way you're able to share it with us is just truly remarkable. So I do appreciate, and I learned so much when I listened to you speak about this, because it's such an important area. As Maya mentioned, we have arranged some time for a Q&A. So if you have questions, you can please put them in the Q&A box and I will read them as time allows. If you happen to be on a phone, please press *9 to raise your hand and to ask a question. So we'll take it from there, and I'll try and reduce this and go over to here. We have one question here about how can we utilize these technologies to support drug user autonomy when the funders require and incorporate collaboration, additional surveillance systems for overdose mapping, heavily involved law enforcement, just reading it as it's written. So.
Well, I mean, that's the $1 million question. I have a couple ideas. I also, I imagine that the person who typed this probably also has some additional thoughts. So I would definitely invite you to comment if you have some thoughts on this, or if anybody else does as well. But I'm gonna, my broad strokes thoughts on that are severalfold. One is it is probably the responsibility of us who do drug checking to put together enough of the kind of evidence that feels reliable to funders. So like, we probably need to do some of the research that quantifies the acceptable components of a drug checking initiative to people who use drugs. I can tell you anecdotally that the biggest barrier to launching the Chicago drug checking project was that people were afraid of us sharing the information with law enforcement and police. So the real question is, if you want a drug user facing drug checking initiative, you actually must firewall the data from law enforcement. And aggregate data is one thing, but absolutely individual level data, there absolutely must be a firewall, or else it won't work. And so the question is to funders, like, which is more important? And if there's funding and money, which there is, for HIDA, DEA, law enforcement surveillance initiatives, then separate it out. If there's money to fund this, then perhaps there's money to fund a harm reduction based drug user facing initiative, complete with the data firewall. And so, you know, as we've seen that the responsibility for creating the evidence falls on harm reduction programs for proving syringe distribution works, justifying smoking, you know, giving out pipes and smoking materials, giving out naloxone. I mean, there was literally 20 years when we were giving out naloxone during syringe service programming, where funders said, there's no evidence this works. I mean, that literally was the first 20 years of naloxone. So I think that there is also some responsibility on us to make that happen. And I would also encourage you to like get together your roster of research that highlights the vulnerabilities of law enforcement involved surveillance in the health and well-being of people who use drugs. And I'm going to drop an article in the chat that just came out really recently that describes the fentanyl seizures, so surveillance seizures, and being associated with an increased number of non-fatal overdoses in the direct spot, in the exact geographic location where that seizure occurred. So I'm gonna drop that one as an example of collecting the evidence. So any other thoughts?
That was perfect. It was interesting, I think worthy of note too, as I read this and think about this question in detail. When we first approached Maya about even doing this, her first response was, I'm interested in doing this under some very strict conditions. And that was really not to embolden law enforcement. It's really to make this really, I'm not representing it very well, Maya, but I do remember you kind of talking about that. Like, you're good to talk about this from the harm reduction side of things, but not to create some other kind of net by which we capture people, so to speak. So,
you know, I mean, I think that's it, is that it won't work. That's just all there is to it. Is if if a drug checking initiative is owned and operated by law enforcement, and you want to do it the way we're doing drug checking, it won't work. It will barely, honestly, it will only barely work if it's a research project. People who use drugs are some of the most researched people on, in the country. The only way it would work if it's a research project is if a considerable amount of the staff are indeed people who use drugs from the community that is being researched. So it just, that's the other thing, is it just like won't work,
Right.
So
Yep.
Yeah.
I have another question here from our audience. Do you have any resources that debunks the quote fentanyl and marijuana end quote narrative? I hear statements around this all too often.
Yes. Yes. So I think that probably the most, the places that I would go first is, oh my gosh, does anybody know? It's that like Drugs, Truth and Media resource that was put together by like Maya Salovitz, Change the Narrative. That's what I would do. So there's some research by a lawyer named Corey Davis that looks at media mentions of fentanyls, particularly fentanyl in marijuana. And so that's a research article that's helpful by Corey Davis. But the Change the Narrative, and I'm going to try to Google it right now and drop that in as well, is I go back to it all the time. And that is, the other thing, and this is kind of what I mean by reality based, is we really need to walk through the logic. And if the logic doesn't check out, then we must triangulate it. So what is the logic of there being fentanyl in marijuana? Marijuana is widely available in the state, moderately affordable, pretty high quality. There's no lack of people interested in acquiring marijuana. So it's not like I've heard this nefarious, like drug suppliers are putting fentanyl in this X drug supply so that people will become more addicted to it. Like, there's like, so none of the potential logic really checks out at all. And so what's the logic? And and then the other thing is that, actually have it checked, have the marijuana checked, have it sent to a GCMS lab, send it to the drugs data people, have it run through a GCMS or LCMS or run through a crime lab, and show me the spectra. That's another thing that I think is also really important. So
very good, thank you. One of the other questions that comes up, we get some pushback, and you talked about it already a little bit, but you could revisit it again, is analogs, particularly with the fentanyl and the resistance to some of the drugs, the strips, the drug checking strips and the analogs. Could you revisit that a little bit? I thought you did a great job saying they really narrowed it down to the types of analogs, but could you talk about that just a little bit more about, we have gotten some pushback from not law enforcement, really a recovery community, places that are hesitant about the fentanyl test strips.
So see, the fentanyl test strips are really interesting. One is that the CDC has just recently said that that existing SOR block grant funds can be used. The CDC has also said so, can be used to purchase test strips. But I think that we need to be cautious about laying over the distribution mechanisms for naloxone on the test strips. The same pool of people who should have their hands on naloxone are not necessarily the same pool of people who should have their hands on test strips. The people who need test strips are people who use drugs, any drugs, but people who use drugs. It's not useful to have, somebody who's a non-drug using parent or partner of a person who uses drug have fentanyl test strips the way it is to have naloxone. So we need to focus our naloxone or our fentanyl test strip distribution a little bit more narrowly. But also, I think it goes back to just a rote moral hazard argument of which comes first, the knowing that it has or doesn't have fentanyl or the use, but there's people had are not emboldened to use more if, depending on the results of their fentanyl test strips, people were planning on using anyway and can make different safety decisions based on the results of their drug testing results. However, I also want to say that it is both unfair and unrealistic to place the responsibility for avoiding overdoses on people who use drugs, regardless of their access to drug checking supplies. It's too much to ask in the context of an unknown, unregulated, poisoned drug supply. It's too much to ask that individuals are capable of making all of the we can't behavior change our way out of the overdose crisis because we have a poison drug supply. And it's an unfair expectation on people who use drugs that they be able to do that. Even the most knowledgeable people in the world have been unable to behavior change their way out of overdoses. So
yeah. The real-time availability of results, that strikes a chord to me. Is like, how do we do that? How do we, again, I think I understand that comfortably, but how do we actually get to that point where we can get that reliable real-time data back to the people who are asking us life-saving questions?
Yeah, I mean, the only real way to do that is with either fentanyl test strips and or having field deployed spectrometers. So in the absence of that, we can't do real-time drug checking. What we can do is hear, triangulate, and then amplify drug user knowledge. So, in the context of a needle exchange, like if we hear something was really wacky, we want to hear it from that person. We want detailed information, and then we probably want to hear it from somebody else. We want to kind of try to triangulate it because every individual's experience of drugs is different. And then when we feel like we're hearing some consistent feedback from the drug using community, then at the needle exchange is how we amplify it to other people who use drugs. So that's the other thing that we can and should be doing, is amplifying existing drug user knowledge.
All right, I have more questions I'd love to ask you, but Becca's going to conk me over the head if I take up more time here. We try to be respectful of people's time. So again, from me personally, again, thank you for your expertise. It's just, it's awesome. So
thanks for having me. Such a pleasure.
Yes, I echo Matt. Thank you so much, Maya. It's always such a pleasure to have you and your expertise on these lunch and learns. We really value you and appreciate your time so much. Also, thank you to everyone who joined us today for this OT Community of Practice Lunch and Learn. A recording of the webinar will be posted on the CBHJ website and our YouTube page within the next week or so. We will also send a copy of the slides, and there was a request for the invite to the training on your last slide, Maya, so we will also send that out and all related materials to every attendee as soon as we can. Please keep an eye out for our future events in this series. The webinars are held every other month, and the next one will be scheduled in November. And last but certainly not least, it's really important to us that the content we share is useful and relevant to the work that you're doing. And so we would appreciate you taking a moment once the webinar ends by clicking the link that pops up and completing the survey. Thank you again for joining us today, and we'll talk to you all soon.